more folks registered, but it's 2 minutes past now.
I'll follow all of your lead. I'm sure I have too many slides as always. So I've printed out my list of what I would love to talk to you about, and I can cut out and revisit things in our other sessions if we don't get to them. So whenever we start is fine.
Okay, well, I'll do a really quick introduction then. So welcome everyone. I'm Lisa Hayward. I work at the Office of Social and Emotional Wellness. And the pleasure of my month, maybe my 6 months, is to see Cassie again after months of not having seen you. And Dr. Cassie Yackley is one of probably the state expert on childhood trauma, I think. I'm pretty sure you are. I always talk about you in that way anyway. So if you're not, pretend you are. And she's joined us today, and we're really, really honored to have her. But Cassie, before we jump in, I know you wanted to speak to why we had to change our schedule, and I obviously didn't want to write about it in an email because it's not my story to tell.
So thanks. I just want to welcome everybody. It's super nice to meet you. I am so sorry for the change after it took us so long to get everything settled. I was telling Lisa, I was up in Maine. I was supposed to be their keynote presenter for their DOE's Summer Summit. And I was at a vacation rental carrying my kiddos' blankets down the stairs, and they were wet, and said, "Don't slip." And then I slipped and I broke my ankle. And so, oh my gosh, you guys, it's been an adventure. So I have my cast under here. I'm doing pretty good today, but they scheduled surgery for Thursday, and really didn't have any choice when they were going to put it. So I'm super sorry. And I don't think Friday is probably a good idea to come and try to present on camera Friday. My husband said no. So thank you. And I'm really sorry for any inconvenience. Hopefully we can just move that around and make that work. So.
Perfect. Thank you. So Heather, if you don't mind, start recording now. Cassie, it's yours. I'm going to sit back and absorb everything like I do every time I have the opportunity to hear you talk.
Just to clarify, I think it is recording right now. Did everybody get the record button? Okay.
And that's fine. You guys can always edit some way and cut out my talking about my little ankle injury later. But anyway. You know, and I would love to spend time getting to know all of you. For the sake of our time today, what I'm going to do is I'm going to kind of jump in. But since you're getting to know me, recording or not, I completely invite any conversation, questions, discussions. By way of background, just super quickly, I'm a licensed psychologist, and I've worked with multi-generational trauma for a little over 30 years. As you know, I've done a lot with schools looking at trauma responsiveness, but a bulk of my work right now is working with mental health clinicians, as I was telling Dave, training them in child-parent psychotherapy, CPP, and evidence-based practice for 0 to 5. And I have a 15-year-old right now, so that's a whole backdrop to this story as well. So I just wanted to give you a tiny bit of context before I jump in. The other thing I'll share with you is during the pandemic, during all our downtime in the pandemic, I finally had the opportunity to train with Dr. Bruce Perry in the neurosequential model of therapeutics. And I'm doing those evaluations for a number of high-end kids, excuse me, often involved in DCYF or those kinds of things. So I'm going to share with you today, I think, some really cool stuff as we think about the cutting edge of brain-based approaches to kids. And what really like about this is for you all implementing MTSSB systems, it really makes a case for why our interventions at each of the tiers are necessary from a brain-based perspective. So bear with me today as I kind of lay that foundation for you all. And again, if there's any questions or comments, anybody certainly jump in and ask or make comments. Share my screen with you. All right, so here we are officially to the New Hampshire Department of Education, brain-based approaches to education. This will be our first in a 3-part series. In the next one, I'll talk more about relationships as a mediator to fear, and really laying the case for social emotional learning through an interpersonal neurobiology lens. Then our final session, I'll talk about an implementation rubric that helps us think across the T's and across the tiers, and across 5 primary domains of intervention. So we'll do this each in a chunk. Today really is just thinking about the background, as you saw from the objectives, amongst a lot of other cool stuff I hope to share with you. I want to make sure that folks have an opportunity to understand what state-dependent functioning is, to think about, especially from a Cozzolino perspective, the optimal conditions to learning. And I want us to think a little bit deeper about student engagement and motivation. And I know that's a lofty goal, but when I've been working with districts over the last couple of years, I hear from more people that their struggle really is engagement, right? And having people be present and engaged in what's happening. And I think that's true for staff or students. So those are our general objectives. And I will give anybody, if folks are interested, I can share a PDF of my PowerPoint today. Lisa will attest I'm super obsessive. And so even this morning, I got up and changed slides around. So I typically don't deliver them until I'm done.
Cassie, if you email me the PDF, I can also send it out, because when you're in surgery, I don't think you want to be worrying about email.
Okay, yes.
So if you email it to me, anyone can reach out to any of us in the DOE, and
Perfect.
we'll pop it along your way. Thank
Perfect.
you.
Thank you. So as a broader lens, as we just start thinking about this, I'm not going to talk at all about ACEs today or the prevalence of trauma. That's not our purpose. But I always think about how we embed these impacts. And today we're talking about an individual, but we're always thinking, what does this mean across the lifespan? What does this mean across generations? And as I'll mention a little bit with organizational stress today, across systems, and what that means for the folks that are working in systems with a high number of stressed and traumatized children. So we'll begin today by taking a little deeper look at neurodevelopmental impacts. There'll be a few concepts that are basic, and I'm just putting those up there to make sure we're all on the same page and really gearing us up to think more deeply about state-dependent functioning. Everyone here is, I'm sure, familiar with the statement, neurons that fire together, wire together. And as we begin to think about the nature of interventions, it all comes back to this. What do we know about the regrowth and reshaping or neuroplasticity of the brain? And it's about repetitions, effective, targeted repetitions that allow particular brain regions to go. So we're going to keep this in mind as we start thinking about how to change and grow brains. Most of this obviously is really shaped around our understanding of what happens with fear in the brain. And I know all of you as virtual experts out there have a good sense of what that means. And so, yes, at the foundation, we're reminding folks that it inhibits our capacity to utilize the prefrontal cortex, while it strengthens lower connections around the bottom part of the brain. We're all remembering in our head that part of the other important pieces of brain growth information is based in the principle, use it or lose it, right? So if I don't use a particular region of my brain sufficiently, its neurodevelopment can be compromised. And by the same token, excessive use of a particular brain region or associative area can cause it, as I mentioned before, to be hyper responsive or sensitive. I'm not going to spend time at this point going through each of the primary regions of the brain, but just reminding folks that when we talk about compromise of the prefrontal cortex, it's really everything that allows us to function in the world. It allows us to learn from consequences, frankly, which so many of our systems are built upon. It allows us to set goals and think about the future, to think about ourselves or other people. And it certainly drives our ability to start or stop our behavior. So there are profound implications when we begin to think about lack of development in this region. It's important to mention memory if we're going to think about stress and trauma, and I'm thinking about an entire continuum here, as I'll talk about in a moment around stress vulnerability. But there are very particular impacts of stress and trauma on the way in which we encode memory. And what we know about that, and I'm sure you're familiar, is that experiences of stress or trauma actually increase the unconscious implicit memories that we have. And those memories are largely sensory motor experiences, emotional experiences. It's the feeling we get when something happens. We don't have access to that via our prefrontal cortex. And at the same time, it inhibits encoding through the hippocampus in terms of long-term memory, right? So we get this incredibly strong, what they refer to as emotional tagging, strong memories of, oh my gosh, this is how this felt. And that could be true of, as we'll talk about next time, what happens in a relational dynamic. It can be true of how a kid or a staff feels simply by an interaction with a teacher or another student or an academic topic. It wasn't patient with me. I didn't do that. So we start to think about this inability to encode long-term memory and really significant implications for our ability to do chronology, to sequence things. We also begin to lose our sense of time. And I'm sure folks are familiar, just very grossly speaking, we're thinking about these two forms of memory. Explicit memory really are target of academics by and large, typically, all the facts and knowledge that get accumulated, but also episodic memory. Like, I remember this story about me, which helps in identity formation as we're getting older. Versus implicit memory, which are much more like procedural forms of memory. And then, as we've talked about, right now, this either priming or emotional or sensory motor type of emotions. We know that 95 to 99% of anybody's behavior on a daily basis is completely implicit. In many cases, we won't get into this a ton today, but in many cases, our job is bringing forward implicit memory so people have some tangible control of what's happening for them. So this is Bessel van der Kolk. A great picture of him, huh, you guys? I just kind of left it. It makes me chuckle a little bit. But he's saying really the most difficult and traumatic memories are stored in non-verbal bodily memory, excuse me. And we'll come back to that around the sequence of engagement. So think about this. It's not just memories out there. It's all these internal experiences that also need to guide our reactions, like physiological responses, as I've talked about. These are automatic. It also includes things like implicit bias would be in this category. And the more stressed we are, the more traumatized we are, as we'll talk about later, the smaller the window of tolerance, and the more, frankly, that things become implicit in that process. I already did that. I'm just reminding folks here that when we think about neurons that fire together and we think about neglect or deficits in particular regions, this is a brain scan of a 3-year-old. On the left-hand side, a typically developing 3-year-old. And on the right-hand side, an extremely neglected 3-year-old. And I'm sure as you guys are looking at the images here, it's quite obvious that the images are not the same size. Their circumference of the brain for the neglected child is much smaller. But then also when you look within the image, you're seeing these big black cavities, especially on either side of the middle of the brain, the corpus callosum. And this has particular relevance because, as you know, the corpus callosum allows us to communicate the left and the right side of the brain. This logical, language, linear part of our lives, meaning-making part of and language-based part with gist and sensation and emotion. So if I have no connectivity between those things, quite literally what it means is I don't know how I feel, or I can't put a word or a name to it. And I'm really dependent on other people making these pairs between my experiences and emotions and what this all means and what's happening for me. When we think about across the lifespan, as I talked about on our opening slides, the problem is when neurons fire together, often that firing together creates this path of fear. It becomes the path most taken. And my work thinking about schools is part of our job is to have enough repetition in the other path, not the fear path, in order to create a new potential pathway in the brain. And it takes a lot of us. Doesn't take a therapist or a mental health provider, but it does take a lot of repetition in order for that to take place. my first article that really kicked me off to understanding and having this really drive my work was reading Bruce Perry's How States Become Traits. I read it the first year of my doctoral program in 1995, still remember. Really fascinating, because it talks about how if we have a particular arousal state, right, a level of stress or upset, and we spend enough time and neurons that fire together, wire together, it isn't just a state anymore, right? It becomes a trait. And sometimes in psychology, we end up calling those personality disorders. But those are really enduring states that we haven't intervened with successfully, so that they remained a trait. It did not become some kind of state, but that's a whole nother discussion. And so the other way people talk about this is sensitization of the fear response, or the kindling effect, right? It's so primed for threat and fear and defense that it picks up any micro threat. And when it picks up any sense of threat, the response gets bigger and bigger and bigger and more exaggerated. And it is why we see behavioral responses that are very disproportionate from what happened. Well, of course, right? The arousal system is already so fired up that it doesn't have very far to go to flip your lid or fall out of the window of tolerance. So I'm going to pause for a quick sec, because I'm going to transition. That was our super fast reminder of neurobiology of fear and trauma. I just want to check in with you guys and see if there are any questions or comments about anything I've shared so far. Is this making sense so far? Okay. So now we got that foundation behind us. Let's think a little bit more about early development and exposures to stress or trauma, and then what that might look like or mean for functioning. So this is a summary slide, and as you can see, I put on the right-hand side the ACEs pyramid, not the extended ACEs pyramid, but for the sake of the day today, just this simple one to help us think about what these mechanisms are. And so disrupted development, there's three primary pieces that are important to us. Number one, this overdeveloped fear response system, which I've mentioned several times today. Number two, and this will be the focus of next time, really, this inability to use another human relationship to feel safe and to regulate. And when we can use other humans in our world to feel safe, in the clinical world, we refer to that as secure attachment. So what we're talking about is this ability, to even begin to feel safe, but then the most important precursor to self-regulation, with that, which everybody's after, is co-regulation. Nobody learns to self-regulate until they feel safe and they co-regulate. And again, we'll talk about that extensively next time. But then lastly, as we mentioned, the lack of development in the prefrontal cortex as development is occurring. Most of my work, and I would posit that many of the challenging students that we deal with and families that folks deal with really were early exposure to trauma, and often pre-verbal, 0 to 3. So contrary to popular belief, the most likely time of traumatic exposure is 0 to 1. And the most challenging impacts to the brain occur with neglect and stress and trauma between the ages of 0 and 3, especially the ages of 0 and 1. We'll talk about that specifically, obviously. So we're reminding ourselves that there's some general principles that have to happen as the brain is developing. Number one, it has to happen in a sequence and a hierarchy, bottom up and inside out, as it does when it processes information. We're remembering use it or lose it, which means that in order for a brain region to develop, it has to be used, use-dependent development. And this is going to be true when we think about neurodevelopmental interventions as well. If you're not exercising that part of the brain, it's not going to return to its normal developmental trajectory. And it all happens through experiences, whatever experiences that we're able to provide for people together and hopefully across our systems, frankly. So if we begin to think about this in a little more sophisticated manner, when we're doing NMT, the neurosequential model, the brain is divided into 4 general regions. Most people are familiar with these. Usually it was done in 3 regions, but for the sake of this approach, we're now pulling apart the brainstem, which is really autonomic nervous system functioning, and the cerebellum and the diencephalon, kind of the next part to develop. And that's really has to do with proprioception. It's involved in our arousal level. It helps with motoric control. Think about catatonia in things like schizophrenia in this ultimate lack of ability, right? So you can see where we get these impacts that are about our ability to control our motor system. And then a little bit later, developing and more sophisticated is the limbic system. And again, grossly speaking, right, it's involved with emotional understanding and relationships and the intersection between those 2 things. And then last but not least, the prefrontal cortex or executive functioning region. The bottom of the brain is earlier to develop. The things that are earlier developed have less plasticity. They're harder to change. So it requires more persistent intervention if something takes longer to change. But remember, things have to happen in a sequence and a hierarchy. So we can't simply say, well, it's easier to change a thought. It's more plastic. It's more malleable, if you will, if the primary issue with dysfunction is happening much lower in the brain. We won't get access to that thought. And we'll come back to that later. So we can think about it this way. This is just a simple graphic, the same 4 regions. And you can imagine the brainstem there in the red. It's all going to teeter upon that, right? So during that first year of life, in utero, in the first year of life, when we have all this brainstem development, whatever that bottom building block looks like, everything else is going to be dependent and teetering on that. As you can see, if you think about the diencephalon and the cerebellum, and then the blue of the limbic system, and then all these cortical functions. And I could spend a long time. I'm trained in a national 2-day training that looks at the intersection between trauma and intellectual and developmental disability. This is just a simple handout, really nice one from the National Child Traumatic Stress Network. There's lots of amazing resources that can help educators think about the intersection of these 2 things. I hope it'll be clear as I begin to talk about neurodevelopmental deficits in a few slides, why this intersection is so apparent. But suffice to say for now, we know that, yes, go ahead, Stephanie.
I didn't mean to interrupt you.
Okay.
I was just wondering, and I don't keep up with this because I'm not a clinician, but I was wondering if developmental trauma has been added to the DSM at this time.
Not yet.
It hasn't. Okay.
No, I mean, we could talk, right? There's so many politics associated. And to be really honest, it's so tied in with the American Psychiatric Association and a medicalized view of things that we're not there yet, but she's referring to developmental trauma disorder. And I'm sure many of you have heard Besser Van der Kolk's take on that, and many of the other primary experts. I think it rings really true, and you probably feel some of these categories, I'm talking about them today, resonate with that diagnosis and that approach, and what we know is those 4 primary dysregulatory areas. Yeah. I cut it all out today. One of my favorite topics is trauma and misdiagnosis in youth. And so we can think a lot about why what we see is all these traumatized kids coming into our school systems with a host of different mental health disorders, all of which are, just trying to pinpoint what we know is the issue. As I see people nodding, right, is all this neurodevelopmental deficit and what we do with it. So.
The DSM, the 5, they've just a new version, the TR has been, I know you know, Cassie, has just been published, and one of the focuses is childhood. I don't know, have you read? I haven't got my hands on it yet. It's coming in the mail, but I know that the DSM-5 TR has got a revision for some diagnoses for children.
Yeah, I mean, as Lisa knows, I'm like a walking can of worms, but as somebody who spent a lot of time doing psychological evaluations and diagnosing people, I also have an expertise in autism and used to teach in an autism program. I'm going to be honest, I don't love diagnosis. I have a lot of regrets about my use of diagnosis in the past, hopefully always ethically. Unfortunately, and then I'll be quiet on this, unfortunately, there is just as much stigma associated with being given a mental health diagnosis. And when we think about distress, not disorder, it's a very different experience to think, you know, I have bipolar disorder and my dad had it and it's a disease and I'm never going to get better, than a frame of saying, actually, the symptoms that we see are exactly what we would anticipate based on what I was just talking about now. And here are the kinds of things we can do to make a change for that. I mean, that is transcendent for people. I remember a woman, I did a 2-day training for recovery workers out on the seacoast. So folks out in the field, right? Really meeting with people in active use. And we had 2 full days together. And I do the same material with other people. I talk about it differently when I'm with different folks, but we did the whole 2 days, and she came up to me at the end of the 2 days, all like teary, and she says to me, "Oh my gosh, Cass, you know what I realized after these 2 days? I'm not crazy. I'm not mentally ill. I've been traumatized." Yeah, right? Just they get to own that story. So anyway, all that to say, I guess a primary message from me is look for adversity. Everybody has a story, especially now since COVID happened. And rarely in my experience of over 30 years is it a genetically, biologically based mental health disorder. Rarely. I do know a few cases, probably on 2 hands over hundreds and hundreds of people. Anyway, I see your nods, you guys. I know we're in the same place. And I know, Dave, you're in community mental health where I spent 12 years. So I know you see the same struggles with what we're trying to figure out with these just folks that have really been in a disadvantaged position and traumatized over generations. So are we doing okay, folks? All right, I'll shut up now and get back to the PowerPoint, because as you can see, I could go awry. So thanks for the question. So what we know, right, is that trauma can cause an intellectual and developmental disability by way of definition, and having an IDD increases dramatically the likelihood that you'll be traumatized and traumatized again. And so there's an incredible intersection. I hear a lot of folks talk about, you know, IEPs and all the kids we have with trauma and how to grapple with how we do effective student planning and whether IEPs work. Again, another topic for another day. So I want us just to think about development and what's happening during those first 9 months. And so that's when the brainstem is developing. Remember, bottom up. So critical functionings that are happening is the regulation of arousal and sleep cycles, my ability to manage a state of fear and get re-regulated. So the goals at that time, right, when I'm just that first 9 months, is just being able to calm down and get back in a regulated state, to be able to feel hopefully safe with at least one primary caregiver, whoever that is, to become a little bit more flexible in my stress response. Think about a newborn and a 9-month-old and the amount that they can tolerate in terms of having their needs met. And then resilience, really being able to bounce back. And in this case, what we're talking about is to come back to a good regulated state after being dysregulated. So what grows that? What do we need if that's the part of our brain? Rhythm and touch grow the brainstem. It doesn't matter, frankly, if I'm a 2-month-old or if I'm 60. Rhythm and touch begin to grow that part of the brain. So this is a chart that I'm sharing from the American Academy of Pediatrics. I love that these came out, and it's a great article if anybody's interested. And what they're recognizing here, as you can see, in terms of response to trauma and really giving some anticipatory guidance for pediatricians, is if there's traumatic exposure in utero and then 0 to 1, here's actually what we would expect to see. Now think of how many kids we're talking about, even up through high school. So primary problems with sleep. Yes, the problem is trauma impacts the reticular activating system. And so what you're going to see is trouble falling asleep or staying asleep or some kind of nightmares, right? Well, the brainstem is also responsible for satiety. So yes, we'll have problems with eating in some kind of way. overeating, undereating, hoarding, picky eating, rapid eating. I can't believe how many kids I'll do evaluations on now. One of the signs in the Nmt evals I do is gagging, and do very extensive record reviews. You won't believe how many kids I evaluate that had gagging issues, which now I know are all associated with this primary brainstem issue. And then last but not least, toileting issues. It messes with the release of catecholamines, which impacts the way in which our system is able to move things along, if you will. And so you're going to see GI-related issues like constipation and encopresis or enuresis, or some kind of regression in toileting skills. We started training people in CPP and early supports and services. That's where our traumatized kids come in, because they come in with these primary adaptive struggles. And so do the kids older that we're working with within schools. So if we think about a little bit older now, and notice the time increments can get larger as time goes by, because our brain grows so very rapidly early on. When I'm doing an evaluation, we first look at the first 4 days, and then the first month, then the first 3 months, and then it gets broader and broader as we move across the lifespan. But during this period of time is the primary diencephalon and cerebellum development, as you think about kids being able to move around, right? Being able to crawl. So what's happening in terms of functioning is all this, we're learning how to integrate all this sensory information, and think about what they're doing with their fine motor. We're learning to control our fine motor functions. So right now, my job is, and again, I'm talking about 6 months to 2 years, but I want you to think of the kids that we work with that have trouble with sensory integration or fine motor problems. How many times do we see these on an IEP, right? So what do I need to do in order to address that part of the brain? I need to move my body in complex rhythmic movements, dancing, those kinds of things. I need to experience emotional and physical warmth, nurturing, and closeness. That's what we're doing with little kids from 6 months to 2 years. And we're already beginning to develop a really simple story about who am I, right? Largely based on what we see in our caregivers' eyes, as I'll talk about next time. So I need a lot during this time. And you can think about what we do with toddlers. I need music and I need movement. So if then we move up and we start thinking about somewhere between like 2 and 4 years of age. I think I put 1 there. It's supposed to be 2, but it's under my little menu. I apologize. This is really limbic system development. Not that it isn't some develop, but this is the primary burst of development. So during 2 to 4 years of age, it is the foundation of social emotional learning. So critically, I'm beginning to understand my emotions and to manage them, express them, modulate them. I'm getting better at knowing pragmatic language, right? Interpreting people's nonverbal communication. This is why so many kids that have trauma also get diagnosed, or people think they have autism. My last eval, what was her diagnosis? It was like rad, schizophrenia, autism. I'm like, okay, come on, folks. Really, this poor girl does not have all of those things. She's had horrific trauma, goodness sakes. And the problem with that was the medication regimen, of course. So the developmental goals are, how do I regulate my emotions? How do I begin to put myself in somebody else's position? And empathy is like, I feel it like you do, right? And then I'm also getting beyond my primary caregiver. Maybe now I have other primary caregivers, or I go to daycare, or childcare or preschool. So I'm affiliating with other people and increasing my level of tolerance for distress. So what am I learning to do? I have to learn to move my body in complex ways. I have to start to create a story about my life. And I'm beginning to engage in an increasing number of social experiences. So help me play. Help me use creative expression to begin to understand myself. So really that takes us up the pyramid, if you will, and I'll pause again and just check in with everybody in a moment. But that really takes us up the pyramid another rung, right? Because now that disrupted neurodevelopment that we've discussed has led to the interruption of what we would anticipate when kids enter school, And that is sufficient development of emotional, social, and cognitive skills. And just briefly stated, right, this ability to even identify how I'm feeling. At the most extreme, it's called alexithymia. I've worked with adults that literally, like, I know I feel something and I'm upset. I don't know what it is. No association there. And then, as we'll talk about next time in detail, it's not just social skill development. In fact, that's the least important thing. I'm going to be honest with you. It is, what is somebody's ability to connect with another via attunement, to get a sense of where somebody's at, to adjust their behavior accordingly so that relationships and interactions are enjoyable. And then attachment, as we talked about. Can I really feel safe with any other human in the world? And many kids that we work with, right, they don't. Literally, sometimes they can even feel safe with one adult in the school. And the teacher will say to me, oh my gosh, they were great with me yesterday. Today they hate me. Yeah, because they got close and now it feels unsafe, right? This unpredictable ability to be safe with others. And then obviously cognitive development. So now if we revisit the American Academy of Pediatrics and we think a little bit about down the road, what might that look like? So again, now they're talking about responses to trauma in terms of behavioral manifestations and what we might see. I'll do this and then I'll pause. So I haven't introduced the window of tolerance, I realized, yet. So we'll talk a little bit in a few minutes about our 2 adaptive responses to threat. And one, as folks are familiar, is fight or flight. And that is associated with an adrenaline response, a cortisol response. You can see that on the bottom. If fear is inescapable, overwhelming, intolerable, the other adaptive response to threat is to try to disappear or to dissociate. It's dopamine driven, right? You kind of disconnect, as Ruth Lanius talks about, in 4 ways. You disconnect from your body. You just literally, your sensor connectedness to your body. That's why grounding techniques work. You disconnect from your emotions. And think about it, if you're getting eaten by a lion, you don't want to feel your body. You don't want to think about how scared or sad or upset you are. You disconnect from your thinking, right? You don't want to think about what's happening. You go a distance from that. And then last but not least, you disconnect from the passage of time. So if I spend, remember how states become traits. If I spend a lot of time disappearing, numbed out in the world, we're going to see this more often with females or young children, those who can't escape or defend themselves in stress and trauma. So the response is like this detached numbing, or the kids that are internalizers and kind of perfectionists and their robotic compliance, they just go along and try to fly under the radar. Often later, we end up diagnosing them with things like, as you can see here, depression or inattentive type of ADHD or developmental delays. And on the flip side, if I've had this more hyper-aroused response to threat, last thing, and then I'll come back to you guys, adrenaline based, which is going to be more common with older kids, with males, then what you see, right, is not hypo-aroused, but hyper-aroused, aggression and hypervigilance and anxiety and exaggerated startle responses. And then diagnostically speaking, often those look like ADHD or oppositional defiant disorder, conduct disorder, bipolar, etc. So hopefully what we're looking at here before I talk with you all is how much we miss these early neurodevelopmental building blocks, and how we can get misled with these diagnoses that then don't allow us to do what we were talking about, all those previous slides, which is addressing those neurodevelopmental needs as they need to be done. So I'll pause now. Thank you. I didn't see who had their hand up.
I did.
Yes.
Cassie, going back to your earlier slides about traumatic experiences in the, birth to 1 year or whatever, I have a question, because a traumatic experience, what does that mean in that time? Because is it like waking up and mom isn't there? Or is it waking up or, being hungry? And my perspective is always from the sociological model. How much pressure are we putting on particularly mothers, to be 100% there all the time, if, you know, just being sick after you've breastfed is possibly a traumatic situation for, I know you know exactly what I'm talking about. Can you speak to that a little bit?
Can I also add, because I'm curious if you
Sure.
talked about like during pregnancy as well, like what that's sort of defined as during that time of what would be, how that would affect.
Yeah. Stress is inevitable, and it's not actually bad for us. If we have buffering relationships and it's moderated, it's tolerable in some kind of way. As Lisa knows, my world is often the high end of traumatic experience. I'm not talking about the normal range of parenting. That being said, as we've talked about before, we're all on a continuum of sensitivity or vulnerability to stress and trauma. And that's a continuum, right? All the way from a mild stressor of not getting breastfed when I needed to, as you said before, to in utero drug exposure and domestic violence, which increases alarmingly during pregnancy, which I didn't know until a few years ago. So sometimes they talk about dandelions and orchids, that biologically speaking, some folks are much more hardy than other folks. And so truthfully, Lisa, like, could you have temperamentally a baby that was super sensitive and maybe a mom that had a very difficult time with that level of closeness? We could get into a whole bunch of other reasons. Could that potentially create neurodevelopmental delay or difficulties in primary attachment and regulation? Sure. It could. And we've had babies born. We have a CPP case where the mom had, early postpartum depression, but still high functioning person. The kid isn't a mess, but are there issues with their ability to calm together? Yeah. So I'm not going to make any assumptions, regarding where somebody is at with those early experiences. What my concern is that we often minimize those. Once somebody's at past age 3, we're moving on and trying to intervene in the brain, if you will, at much higher levels. I want to make sure I got Heather's question, and I may have lost my train with that. Can you help me, Heather?
Yeah, I was thinking, and it's kind of basically what Lisa said, but basically like the trauma in utero too, like you were kind of alluding that some of those experiences that happen during pregnancy can also have an effect later. And I was just curious of like what, I guess it would be like, what would be examples of that? But I think you kind of said it too, like just those sensitivities of what, women and babies might be and how they, genetically how hardy they are, I guess, for lack of, better explaining.
Well, and what's happening in the world and all those interactions. Yeah. I mean, I worry with masks. I mean, there's all kinds of things we could think about with those kinds of interactions. But I'm not a perinatal specialist. I will tell you, I'm really excited. The newest extension of CPP is perinatal CPP, and they are going to be rolling out training. We have folks that work in perinatal settings. So my experiences with perinatal insults are typically parent substance abuse issues and domestic violence during those periods. And because the brainstem and even the diencephalon are beginning to form, would those have an impact on the fear system? Absolutely, even prenatally speaking. We know there's a release of cortisol that can impact the fetus. So yes, those can also prime that system as well. And I'm not trying to convey to anybody, and I don't think you would take it this way, that I feel like early exposures are a doomsday. Quite the contrary. I feel really hopeful when we get it right and we don't try to intervene top down, and we get enough people doing the right kind of intervention. We see pretty rapid change in growth in kids. So that's always my hope, is that if we get where we need to intervene, we can do what we need to do to make a difference. But often the other problem that happens is we're relying upon just the teacher or just special ed or just the mental health therapist in the community mental health center or just the OT sessions. And none of those, if they're not happening in coordination, are going to be sufficient to produce change, in my opinion. Yeah, Stephanie.
Well, I'm really glad you said that, because I think that often when we do, when we think about building a trauma sensitive community. We think about the school and parent nights and, providing this information, but then the risk is that if a mom had a rough pregnancy or had a rough relationship when the child was young, it's like that fear that like, oh my God, it's all over. I've screwed this child up for life and I'm a terrible parent and there's no hope. And which I think can be the message that some parents can get when they hear about all this really rapid neural development that happens from 0 to 3, especially. And so I love that you acknowledge that, leading with that hopefulness that like there are ways that we can address this, and it's not the water, is not, it's not under the bridge. It's like we can do something about this, and that's such an important message to convey when trying to build these communities, I think.
And this has been a long journey of what we talk to people about, Stephanie, and I didn't lead in with some of that today just for the sake of time. But there's always a balance that people be upset or scared or hopeless about what happened. But the balance of what I know is that if we don't help parents to acknowledge the impacts or to put words to the story that's happened, it can have a very negative long-term impact on that child. So there's a thoughtful balance for me about, and everybody I work with usually has maltreated their child and is involved in DCYF and has had their kids removed. And so I'm not saying all parents are like that, but for me, the balance is everybody loves their kids. Nobody wants to hurt their children. They want to do the very best they can. But helping parents reflect on difficult experiences allows them to help their child do it. And that's what produces post-traumatic growth. Right. And it is painful, no doubt about it. As a parent, I can say this, that the thought that you did something that impacted your child negatively, I will say as a mom, is nearly unbearable. Right? Nearly unbearable. So people reckoning with ACEs, it's a lot to reckon with. And what we always do is think about a double scoop. Because I can say to that caregiver, of course, given your experiences, that's how interaction happened with your child, of course. And what are we going to do about it now? So trauma work for me is speaking the unspeakable. And there's always a hard piece to this. I'm optimistic, I'm a hopeful, but I'm also honest and a realist. And the reality is, if we severely traumatize or neglect a child between the ages of 1 and 3, the likelihood of intensive intervention is high. That's just the reality, as you know very well. So anyway, I'm glad you said that. And I think, thanks for having me, Lisa, because I think there are a lot of people who could come and speak to this topic. I don't anymore even really speak about SEL. I want us to talk about adversity and what we do to help parents and kids deal with specifically the adversity that's been happening. And if we get time during a subsequent, I'll do it during the 3rd session. This last year, we've been implementing Miss Kendra's curriculum in classrooms, elementary school classrooms. And if people saw the movie Resilience, they featured it toward the end, the curriculum that talks about rules of safety for kids and introduces it at the tier 1 level as a primary intervention program, allows kids to talk and write about worries in their lives. Oh my gosh, you guys, you would not believe what teachers and kids told us this year. I get goosebumps. It was magic. I'm not joking. And what the teachers told us, I'm just pulling together the evaluation from this. We're going to continue this week. What the teachers told us is most often the kids totally calm down after Miss Kendra's. And parents are the same way. They're dying to talk about the hard stuff. And my experience is when I say to parents, my God, the world's hard. What kind of hard things has your family been through? Most parents are pretty forthcoming. Yeah. It's the frame of how we approach it. There's a lot of schools I'll talk about in 3rd session. There's a lot of schools that implemented a little screener I came up with called the Family and Child Experiences Questionnaire, where they screened like every kindergarten kid at their at the opening portion of the year. They gave them a little screener, and it was just asking in a really benign way, what upsetting things have you and your family been through, and have there been any concerns that you've ever noticed with your kids? Some of the school counselors or people who did those said that, like, 95% of the parents did a follow-up. They disclosed something had happened and then said, yes, I'll follow up. And then we're in a good position because we're in kindergarten, right? We can just kind of get things wrapped around that kid for a good early positive start moving forward. Any other comments or questions while we're paused here? I think the hardest thing, one of my favorite phrases, and one of the hardest things for children and families, and Bowlby talked about this. There's a really nice article, and it's what's known but can't be spoken. So much of our kids' lives are like that. They know it. They know all this is going on, but nobody dares speak of it. And that's kind of torturous, right? Nobody making meaning, especially when you piggyback that with what we just talked about with implicit memory and deficits in this ability to put words and meaning to your experiences. So what happens for these little ones and bigger ones, right? Very intense emotional tagging and responsiveness, and no words to go with it other than keep your hands and feet to yourself, or you have trouble with big emotions. No pairing that with the experiences that we knew were contributed to whatever that behavior brain growth is. So
just really quickly, Cassie, you've used the term emotional tagging.
Yeah. So often they talk about implicit memory as emotional tagging. And do you ever walk? I think of it often with a person. Have you ever met somebody and right off the bat, you're like, I don't like them? Maybe that's never happened. Come on, you guys, you've done that, right? Right? That's emotional tagging. That is like this, he's laughing, right? You're like, I don't know what it is. I just met you and I can't stand you. That's emotional tagging. Just to give you an example how something comes across, you're like, I don't know where it's coming from, but I just know I don't like it. That can happen with lots of different micro interactions. It can happen with settings. We often call them triggers, right? In some ways, yeah. That's really what a trigger is. It's an emotional tag. It's an emotional thing that grips us. And in PTSD, the way you get control of that, eventually, it doesn't go away. I know mental health clinicians, I mean, it doesn't go away, but you're like, oh, I'm not crazy. It's that. There's that feeling again. When I've worked with people to do the trauma responsive framework, I'll talk about that a little bit in session 3, when we help kids to pair those. They calm really quickly. Teachers are awesome. Paras are the best. No offense, anybody, but paras are the best at putting that together because they're with the kid all day and they see what gets them, and they have a good, often kids disclose to their paras, so they know kind of where it's coming from. They're actually some of my best partners at helping kids make meaning to some of the symptoms that happen for them. Yeah. All right, should I go on again? You're doing okay? Any other questions or thoughts? Okay. Okay. I think we covered that. We were talking about those trauma behavior responses. Touch my screen. Okay, and now we're up to like 3 to 6 years of age and a little bit broader. And that's when we have the great burst of prefrontal cortex development. And we talked about what those functions are a bit earlier. So sometimes, coming back to where you were at, Lisa, sometimes it becomes PTSD, post-traumatic stress disorder. In my experience, most kids don't end up with that diagnosis, at least early enough on, because it doesn't look like that in a kid. It looks like those charts we saw previously is typically what it looks like. But the other thing I did want to highlight that I think is really important to kind of brain-based understanding and intervention is that this category D that I've put in big bold purple here, negative alterations in cognition and mood. This is tricky. This is tricky for academic engagement and for relationships. And often I'm needing people to recognize the negative cognitive triad, because it can be so repulsive interpersonally when someone responds out of this primary belief system. So those are 3 things, right? Core shame is, I am not worthy of love and belonging by another human being, which is at our fundamental nature, as I'll talk about next time. And if I am not worthy of love and belonging as a human, the second thing that follows is other people can't be trusted. This is a gut reaction, right? This is what we were talking about implicitly. This isn't my thought that's running through my head, obviously. And then the last part is, I'm not worthy of love and belonging, and other people can't be trusted. The world is bad. Why hope? Why engage when bad things are just going to happen? That is the tricky piece. And often, I'll talk a little bit the last time, we respond in ways that are just really not so helpful. So executive functioning, critical functioning, connecting emotional and social experiences meaningfully. Beginning to think about concepts such as justice and fairness, right? Abstract type concepts. And so developmentally, I have to be able to reason abstractly. I have to be able to be innovative and creative. I can begin to understand what respect is, which is really the top of a whole bunch of other socially related developmental tasks. And I'm starting to think about values and spiritual issues, or how I make meaning of what's happening. So notice this was like up to 6, right? I'm learning to be okay alone. I see these kids in the classroom when I go in to do observations. They're the kids that the minute the teacher looks at anybody but them, they lose it. They cannot tolerate any level of shared attention. I can feel satisfied in terms of satiety, right? I can put that at bay and be okay. And I can feel safe and secure in the world. I'm learning that I can participate in social interactions and have complex conversations. So if we really want to help kids grow that part of their brain, what do? We do things like drama that allow them to safely do that through expression, performing arts. We do that through experiential educational experiences. And then, yes, if I can get to that part of the brain, thought-based approaches like cognitive behavioral approaches. So we did pretty well. That was 1 hour, and we got through all of disrupted neurodevelopment. Yes. I'd like to talk with you next about thinking about neurodevelopmentally informed interventions, but I just wanted to see if there were any comments, questions, thoughts before I do that. It's been really fun as I start to talk about this neurodevelopmentally based interventions. I've been working with a very large unnamed residential facility here in New Hampshire, and we're doing NMTs on the kids. And then I've also done these with like community mental health, where we've had the mental health clinician, the DCYF caseworker, the school personnel, the pediatrician, the OT, the more people we can get around the table. So for the residential kids, I do these NMT evaluations, which include a very thorough history gathering and a record review analysis of ANS functioning. And then talking about, as I'm going to share with you, what these kids' brains look like and what kind of interventions everybody can do together across each of those settings for a period of time. And then we revisit, right? Are we seeing a difference? Are we seeing a better ability to calm or engage? So it's really fun when you see it happen. And it's when people can really see what that means in somebody's brain, it makes a big difference. So this should hopefully just like piggyback, and we've gotten to this place. It's the same upside down brain model that I'm sharing with you. And I do have permission to share some of these because of the certification process. And so we're just labeling those 4 brain regions that I covered in the previous section. I've just labeled there very briefly some of the primary functions that each of those brain regions are responsible for. So nothing new on this slide other than to introduce this idea that we have to understand things. They call it neuroarchaeology. So can we look at history enough to be able to extrapolate where the brain needs help? And can we do it in a sequence kind of manner? And so that'll make sense as we begin to think about this. So I just had to share some of this with you guys. I don't always share these with people, but I thought you might find this kind of interesting. So imagine now you see the same neurosequential brain layout on that little diagram I put on the left for you, and then you can just follow it over to the right. And what I put in there is each of the regions that are identified that are that region is responsible for. So if you look at the brainstem, you can see those bottom 6 squares. And normally these functional brain maps, as they call them, are color coded. So anything that you see on there that would be a red is severely developmentally compromised. There isn't any on this particular map, but if they were green rather than yellow, then they would be developmentally on target. And normally when I have a evaluative printout, there's a typical developing brain next to where a kid's brain is. So if I'm a 6-year-old, I don't expect all of these to be fully developed, right? They don't develop till later on. So it's developmentally dependent. And so you can see in the bottom, yeah, if a kid was 0 to 1, we're looking for difficulties with suck, swallow, gag, attention and tracking. No surprise there. Temperature, metabolism issues, tracking and eye movement, ocular eye movements, and then arousal levels as well, which I think makes sense. You can then look up at those next two represent the diencephalon, if you will. So you see sleep and feeding and fine motor, all these kids with fine motor issues or clumsy issues in terms of large motor function and coordination, et cetera. And then all the way up to the top. And so if you think about how we'd be sequencing that, you'd go for the lowest area of deficit and get the most repetition you can in that area to begin with. And I could go back to go ahead, Stephanie.
I'm just wondering, because I mean, these are pretty common symptoms, and I'd say most kids have something on this, the panoply of symptomology that you just presented. And I'm wondering, is all of it, necessarily trauma, or are there other legitimate reasons why a student may have an issue with one area or another?
What do you think?
I think there are other legitimate reasons, plenty of them, but I think that there's, a desire to certainly say, well, because, Johnny, was, I was in the hospital and Johnny was 1.5, and therefore Johnny now has an issue with this. And then I think that there's, seeing that, I think you can easily come to the assumption that, oh my gosh, every kid that has a struggle with any of these areas has been traumatized. And I think that's where, that's what we use to justify a trauma-informed approach for all students.
Mm-hmm.
When there are, in fact, a much smaller percentage of the student population that's actually experienced this significant level of trauma that would impact these things. But I struggle with that a little bit, of how ubiquitous is trauma. Should we say that all students have experienced some level of trauma, or should we say, that it's real? I'm curious about what you and what the group think.
Yeah, what do folks think? Not everybody at once, you guys.
I think in some cases it's looking at it across the board of identifying which kids, I like the questionnaire that you talked about, Cassie, because I think there's in the benign way of looking at it of every kid has these, and that you can combine it in looking at, okay, so we have those with the severe trauma, but we have those that have that. And if anything, it has a little bit of normalizing it across the board that all kids have these, particularly in a school, that you can say, okay, we can implement these across the board. So in a sense, we're not even pinpointing kids. We're just creating this as part of our environment, part of our culture in our school to say, let's do this for all the kids, because each of them have certain experiences, and then some you're going to have more. It's kind of even speech for those types of things. You might have kids that need more intensive speech services, but in the classroom they still need to develop those speech things. So it's creating that environment to look across the board and normalizes it for some of those kids that have intensive things, that all the kids around them have some kind of struggle.
Yeah, I mean, Sarah, I think so a couple pieces to this. Yes, we are trying to make the case for primary intervention because it's good for all brains, and no brain looks perfect. My brain doesn't look all green either. There are areas, and understanding that to a degree of sophistication allows me, to be a better human. Hopefully I've learned in my years. What I would also say is I do believe that struggles at school are the result of experiences, by and large, whether we call those traumatic or not. I think we grossly underestimate the amount of traumatic exposure that kids have, and we dramatically overdiagnose autism, dramatically, because of this interaction. And I'm going to give a very specific example of this. I know I don't do autism a bunch anymore, you guys, so if I misstep this, I apologize, but the rate of autism is somewhere between 1 in 54 and 1 in 110. Something like that, depending on where the CDC is at and how we parse it, right? Is that pretty close? Guys, is that what you guys know? 1 in 54 and 1 in 110, somewhere between that range? Yeah. Do you know what the rate of, yeah, Stephanie.
Oh, I just want to, I want to come back. And Sarah, I really appreciate your comment in the chat. This idea, and the diagnosis piece, I think, is a separate piece. You're absolutely right. And it's a huge piece. And, what we end up seeing with students with diagnosis, I think that in the back of our minds, we should be thinking about, potentially a trauma background. But I think I struggle, and I've gone back and forth in my own kind of thoughts about this, about, yes, all kids do benefit from a trauma-informed approach, and the assumption that every kid has experienced trauma is really hard to, it's kind of a, it's kind of a difficult tier 1 mindset to think about. In my work with teachers, it's, they struggle with that, I think, is kind of making the assumption that every kid that walks into the door has potentially experienced trauma. And yes, trauma-informed approaches are good for all. So I don't know, there's like a tension there for me.
So I like brain-based, and that's why my presentation wasn't called trauma-informed, it was called brain-based, because I'm talking about experiences and what that means in a positive or negative way for brain growth, but I'm going to continue where I was at for a moment. It is super hard for us to wrap our mind around the prevalence. And I know many people do not want to be there. So by way of comparison, the rate of autism, I think I was saying, is 1 in 54 to 1 in 110. The safest rate of childhood sexual abuse today is 1 in 10. I've never read an IEP where we're helping all those children who have been sexually abused, including the 1 in 10 today that report sexual misconduct by an educator. So I am not worried about overestimating exposure, because we so grossly under talk about and acknowledge the level of traumatic exposure of kids. So number one, I'd be much safer if we recognize 1 in 10 kids have had even sexual abuse that are sitting in front of teachers. That makes my case. And there's nothing that we're talking about in terms of how we intervene in a trauma-informed way, and that comes outside of what I often say is everybody has a story. And we all do a heck of a lot better in the world the better we know whatever our story was, because it's how we tick. So again, I don't have to keep the word trauma in there. That's a very specific definition, and that's why I showed you PTSD. And it's frankly going to represent a fraction of the kids that we're talking about that end up with, PTSD as a diagnosis. Everybody has their own experiences. I will tell you, working with kids with autism and in a variety of settings, I have probably met under 10 people ever that I've worked with that had a biologically based mental health disorder. That's it. Very few didn't have something, and I'm not saying it was abuse, difficult life circumstances. They had cancer, or they've got chronic illness. So it still means that tending to and understanding that story and spending the time to help somebody else understand that story still is going to produce whatever we want to call post-traumatic growth. So
I really appreciate the kind of the renaming, and thank you for bringing my attention to that you intentionally didn't call it a trauma the brain-based development. I think that's a wonderful kind of reset, because that is something that truly is a universal approach, and it takes away the stigma. calling it, that we're assuming that every kid has trauma. Instead, we're just assuming that every kid has a brain that develops. And there are, conditions that advantage and disadvantage development. We're going to help every kid from where they are.
Yeah. And the high-end kids, the more specific and targeted we can be, the better off we're going to do. A lot of what we're talking about, like Sarah said, yeah, we can do that with all kids. Every kid right now, 0 to 12th grade, at a minimum, should have a regulatory break every hour. And more so the younger they are. Every single child, period, given what's happened, including my 15-year-old advanced student in high school. Not a traumatized kid. Do I think there's been an impact over the last couple of years? Without a doubt. Nobody got by unscathed. And so in some ways it makes our case, right? That we do have to think about. Often I provide a little context behind this. I'm going to just share a story with you quickly, and I'm not going to worry too much about recording or sake of time. And I know we're just getting to know each other, you guys, but I want to share what I usually talk about. Sarah, maybe I talked about it with you before. I can't remember if you've heard me tell this. If you have, I'm super sorry, and you can just like tune me out or whatever. But when I normally present to folks, my very first, besides my gratitude slide, my very first slide says, everybody has a story. And so I tell this story. This is totally true, you guys. I'm just going to tell it for the sake of this today. A number of years ago, I was way up in Maine in Washington County, super impoverished area. And the school districts up there had me for a few days. You've had me for an hour and 15 minutes. You can only imagine in a couple of days what we're going to unearth, right? So anyway, I'm up there, and I am a therapist. I was most of my life, and huge audience. A guy came in the room, and right away I was worried. You guys know what I mean, right? I was just like, oh, I don't know the kind of stuff I talk about, the stats I'm going to share, right? Would somebody leave hopeless if I talk about ACEs and what that means? And this was a long time ago. I got all worried and paranoid, and I was like watching him all day, but I did the whole thing. I didn't change anything. I did the whole presentation. He didn't talk to anybody at lunch. He was on his cell phone, so I didn't bug him. I get through the entire thing. And at the end of the day, he waited like 45 minutes. I'm in the front of the room. I'm packing up all my equipment, and people are chit-chatting with me. He stood all the way in the back. And the minute every single person had left the room, he comes up to me, big, gruff guy. He's got his arms folded. He gets right up to me. This is true, you guys. And he says to me, you need to know something. I didn't think I was going to make it through today. And there's a lot of times I almost got up and walked out. And I was like, oh my God, right? I blew it. I shouldn't have talked about it. I was so upset. And then he teared up, and he looked right in my eyes, and he said to me, thank you. Thank you for talking about those things. And then he said to me, which I've said, and I'll tell you a follow-up to this. Then he said to me, you know what I kept thinking all day? Why didn't anybody ask? They knew. Why didn't anybody ask? So often when I present, I share that story at the outset to say, everybody has those kids. And whatever the story is, it matters that we have the courage to ask, and it allows people to transcend those circumstances. So super cool follow-up to that, and then I'll get back on track. This is a good story. I haven't talked about it. I went up a few years later, and my husband got to go with me. He's a school counselor, so he got PD days. It was awesome. So we're up there, we're driving, and I'm like, I'm not going to tell that story about the guy anymore. And he's like, you should tell it today. We're in Maine. Do it one more time, right? I was like, okay, I'll tell the story. So exactly how I told you today, I told the entire story. The day gets done, and it was literally 10 seconds. I did not know he was there. Guess who walks up to me? That guy. And he says to me, well, I'm not going to make you wait 45 minutes today. Thank you for talking about those things. I got all teared up. Pre-COVID, gave him a big hug. I said, can I give you a hug? He gave me a hug. And I stood back and I looked at him and I said, oh my God, do you know how many thousands of people are going to ask kids about their experiences because of you? Thank you for your courage. So there's so many people to talk about this in so many ways. I'm the trauma lady. We don't get outside of this, you guys, through tier one if we're not talking about difficult things. Our kids are seeing awful things in the world right now. The way we are treating each other as humans, the level of divisiveness, the amount of death, climate change. unfortunately, it is all the kids out there right now. There isn't anybody unscathed and not needing to make sense. Look at the mental health crisis. We can't even get everybody in through the ERs. And in my humble opinion, and then I will come back, it's because nobody's willing to talk about distressing things. That's what our kids need. That's what our teachers need. Talk about the hard stuff. Help me make sense of it and help me make a different world so that I can have hope about where things are going to go. Anyway, that was a super tangent. You could probably tell I'm going to have surgery this week.
Thanks to Cassie is thinking about it. I wonder if it's like for you, Stephanie, maybe the word trauma. And I think that's happened like sometimes in my sessions with people is it'll be like when I'm doing like an intake or something is people have developed this thought of trauma as like, say, sexual abuse or, you know, physical abuse or neglect and like those things. But for some, when I'll say that, like, have you been through something distressing, something that feels like for some, it may be that it feels traumatic for them. It could be something simple of like, you know, my mom forgot to pick me up from school or something like that. And for them, that was like this very distressing thing and could impact in different ways in that thing. And so almost like, maybe thinking of it outside of like that it is traumatic and a lot of them are experiencing those sexual abuse and physical abuse and those types of things, but maybe thinking about it outside of necessarily that word trauma is because I think people have defined it in some ways as just those types of things versus like you're saying, Cassie, of those exposure to simple things out there like people being mean or they're, you know, and bullying and all those things. I think it's becoming more and more for those kids. And everybody, but you know, we're kind of talking about kids.
And I think our topic next time, just the relational understanding of all this is really where it's at. And to your point, Sarah, I mean, you could look at lots of factors. I was adopted at 4 days. Was I traumatized? No, I wasn't in foster care. I was adopted by parents. Do I believe being adopted at 4 days had an impact on me? Mm-hmm. Mm-hmm. And I figured it out, right? I kind of know that thing, and that gave me the ability not to wrestle with it in relationships. So whatever those are, the better we understand, especially relational experiences, the more they inform our current relationships. And then we don't end up doing things like marrying our mother, like I did. I have a great husband now, don't worry. I'm just joking. Anybody ever end up in a relationship and you're like, how are you so much like my parent? Yeah, right? How did that happen? Well, it's the dance we know. All right, everybody, you guys are awesome. I'll move us forward. I know our time is, oops, share. I was pushed leave instead of share. So I usually, as you can imagine, in this amount of time, don't get this deep in with everybody, but I wanted to make sure that I had something new for you guys. So I tried to pull together some of the newer stuff that I think is interesting to take a look at. And Sarah, you're at Northern too, right? Are you still at Northern? Yeah, I mean, Dave and I mean, everybody who comes into mental health, 99% of people I worked with in community mental health had social determinant of health issues or trauma, you know, some variety of, you know, impoverishment or something like that. So, okay, so I'm helping us to begin to think about how to moderate this. I don't want to do that one yet. Hold on just a sec, you guys. It skipped a piece. There we go. All right, so the next thing I would like to talk with you about is based on this same principle. I'm going to share again. There we go. So when good segue to the conversation I want to have with everybody next, because now we're really not talking about trauma at all. We're talking about how our brain functions based on a different arousal states. And that's true for kiddos, that's true for educators, as parents, whatever the case may be. And I'm not just thinking about overt fear here, just put stress on a continuum, and it comes all the way from, you know, mild discomfort all the way to a state of terror, the ultimate state of fear. And then this is the primary premise of what I'm going to talk about. Under stress, we all regress. And this makes me feel better about the last few years and how I've been functioning, I guess. based on this idea that we know the primary function of the brain is to keep us safe. And through neuroceptive process, right, this kind of unconscious scanning of the environment that happens every quarter second, we're trying to figure out, am I safe right now, or do I need to protect myself in some kind of way? And as we talked about earlier with sensitization of the fear response, you can even think of COVID as an example. When you hear the news and there's like a new variant, how quickly now are you like, oh God, here we go again? So even that's an example of like sensitizing that. You're looking on the outlook for what's going on with it. You're more likely to see that danger, and you're likely to have a bigger response when it happens. And by way of summary, what we've talked about happening is that when neuroceptive process becomes sensitized or highly activated, it means that you're having chronic brainstem activation, disengagement of the prefrontal cortex. We talked about how memory shifts when we're stressed, but then also these difficulties with engaging, feeling safe with another, or communicating our needs, interests, or feelings with someone else. And what we've talked about so far was largely brain-based, but obviously this involves our stress response system, or the SRS. And what Pat Ogden talks about is the window of tolerance, or optimal zone of arousal. I think about this all the time right now. Where am I at in the window of tolerance? And where we want to be, obviously, is in the middle, ventral vagal, social engagement. That's like we can handle the emotions that are coming in. We can take in more information without flipping our lid. We're okay, right? And that's a safe space. We can be socially engaged, and we can engage in learning. And as I mentioned a little bit earlier, we have two adaptive responses, and we often overthink about the first response, which is a hyper-aroused response. Our blood's flowing, right? Gets out to our extremities so we can get out of the circumstance. It's associated with fight or flight. But if I'm a domestic violence victim, interpersonal violence victim, or I'm a young kid being sexually abused, or I'm a person of color in an area with a lot of racism, it's not going to work to hyper-arouse. You can look at a military example. A lot of people early in the military die because they haven't habituated a hyper-aroused response. If you're in a battle situation, right, you don't want to jump up and scream because you'll get killed. You want to habituate that fear response and be able to numb out of it. So hyperarousal is exactly the opposite. All the blood is pulled from your extremities in case you're going to be eaten. And I mentioned already the 4 ways we disconnect. I think especially as therapists, you think about these 4 connection ways and what we do in therapy. Ruth Lannius's work is awesome. So your body, your emotions, your thoughts, and the sense of the passage of time. You see this with caregivers and kids that have no idea that an hour has passed, or they're late all the time. I was doing a case consult and somebody was like, I don't know what's wrong with this mom. She had visits. She's like, she's late every time for the visit. And then like 10 minutes before the end of the visit, she's like, let's go get ice cream. And the clinician says to me, who does that? Who messes up the time? And I'm like, oh, I know, somebody with chronic trauma, right? That literally doesn't have any sense of the passage of time. That's why part of the thing like visual schedules help traumatized kids, right? Because it's doing a chronology, which can be really settling. Same model here. I'm just allowing you to think about how those regions are oriented in the brain.
Can I ask a quick question? Like with that hyper-arousal, I think about caregivers, and I like coming from like my background's in teaching, but I also have this background in emergency services, and seeing a lot of seeing a lot of like first responders, police, fire. I'm sure even like clinician, like whether it's doctors or therapists, like is that something that like even people who deal with a lot of trauma, even though they're the ones who are caring, also have sort of those same responses?
Yes. You're awesome, Heather. Yes. And I work with the ACERT teams, the ACEs response teams. I train the police departments. So I talk a lot about this with them, right? A lot of hypo-aroused responding, early hyper-aroused response. And over time, they get numbed out.
Yeah. And I see that a lot. Like I was an EMT, like I have a husband who's a firefighter, and just being around a lot of people who I see that a lot. Like they just sort of get numbed, and people who work in emergency departments, and I even think teachers to some extent when you're around a lot of children who are dealing with a lot of trauma.
Yeah, and therapists.
Right. Yeah, exactly.
right? As a sexual abuse was my specialty, if you will, right? And how do you have a little kid at, oh, I know, Stephanie, I don't bring it up at dinner parties.
No, that's just a fun sentence to say. Like,
oh,
you specialize in treating people who've experienced sexual abuse. You don't specialize in sexual abuse.
yeah, again, not just treating, right? Much more around our understanding and shift. But yeah,
Dave's
certainly.
laughing. I've never seen Dave laugh.
Really? Nice job, Stephanie. I lost my train. It's okay.
Sorry. I didn't.
Oh, it's okay. It's been a week, you guys.
I had a quick question relative to the window of tolerance.
Yeah.
So earlier you had mentioned that like younger children and I think it was girls tend to have more of the dissociative response to trauma, and that males and older children tend to have a more androgenic. Is that what I can't remember the exact word?
Adrenaline-based, yeah.
Adrenaline-based response. And I'm wondering, does that map, or how does that map onto, or if it maps onto that window of tolerance model you were showing?
Oh God, you guys are so fun to work with. Yeah, so part of those differences are epigenetic, right? That over generations, right? Epigenetics are how experiences change the expression of our DNA and how our caregivers experiences. So if you think about epigenetic process, some of it has been that historically women have been in a more vulnerable position where a hypo-aroused response was more adaptive, if you will. But not everybody has just, we're thinking about a normal curve here. It's not like everybody's, all males respond. And in fact, one person can have various hyper or hypo-aroused, us included, right? We all have. So for example, let's say a kid, maybe they were, let's just do child abuse. And so when they hear a loud noise, they don't have any kind of, or when they hear a loud noise, maybe they have a hyper-aroused response. They get all upset and worried. But maybe when they're put in a position of vulnerability and power, they have a different response. They have a hypo-aroused shutdown. So it can kind of be variable. And I think the name of the game is spending enough time to check in with figuring out where people are at in that window and catching kids and people before they fall out of it. And so often what we're doing is the kid's having a meltdown and then we're taking them out. We don't preempt the regulatory need early enough before, because once you're outside the window of tolerance, it's harder, right, to get back in there and to keep it. And I think the other thing I would say about the window of tolerance is it can vary. Sleep impacts it, ongoing stress for all of us. Many of us, our window has gotten very small, and it's variable for kids. So they're, during a good period or a non-triggered time, if you will, it may be fairly broad. And then during other times, it's just super, super narrow. And that just means you have to do those other, I'll talk about the sequence of engagement, those other kinds of activities more frequently to be able to keep you where you need to be. And we just don't do it frequently enough, often. And again, that just comes back for you all to the case of, if there's so many kids I evaluate, if they would just do this in the classroom all the time, then we could cut out half the interventions for the kids and it would be good for the teachers too. So anyway. Okay. Oh, I forgot to tell you guys one little thing before I started, and I normally do. So a long time ago in this online thing, I abandoned chat. I don't do chat when I present because I find it really distracting to others and to me. I can't toggle back. If you have a question, you can ask me. And if you remind me, I'm happy to read the chat when I pause. I just found as a presenter, it was very hard to have two conversations. Even when I'm leading stuff, you guys, if you were doing a group or classroom, you wouldn't allow people to have side conversations like that. It just doesn't make any sense to me. I'd rather the group talked about those things. Anyway. And so I'm going to next introduce the chart to you about state-dependent functioning. And what it's going to show us is that depending on your arousal state, that's the part of your brain that's going to function. So you can see at the very bottom how I have tear. That's a fight or freeze response. That's a brainstem-based response moving all the way up through calm and reflect. And calm and reflect is where we learn and where we transcend difficult experiences. And I'm just going to keep piggybacking on this. So same Same thing you're looking at here, and I'll just orient you. This is called state-dependent functioning, and it means that the way in which the level of arousal we have determines the way in which information is processed in the brain. So if we're here where my red arrows are for now, and we feel calm, we don't feel threatened in any kind of way, we feel safe and pretty relaxed, then that allows us to be reflective, to think about the past and the future and ourselves and other people. That's happening way up here, as you see in the brain region, primary neocortex area. And if you look at those next two rows, the peach row and the black row, those are referring to those two adaptive responses I talked about earlier. The arousal response, the hyperarousal response on the top, and then the disappearing, numbing, dissociative response on the bottom. And because right now we're calm, there's no adaptive response needed, right? It's a restful state. And so cognitively, like we're doing today, we can think very abstractly. We can think about extended periods of time in the future, and we can go back and forth. We can use emotion, we can use body, we can use prefrontal cortex in our brain. Now, if we become alert, which many people are these days, given the world has been falling apart, then what that means is it's not awful. Our first response, frankly, in a mild level of stress is flock. That's why we're doing the next topic, right? How do we use flock to really get people using their reflective process? And so it's a little bit more emotion-based. If I start to move up the arousal, it's not like you're freaking out, but you're vigilant, right? Like we talked about earlier with COVID. And then if you're on the dissociative continuum, you start to avoid. I'll do these last two and then come back. So cognitively, we're less free to engage in abstract kinds of thinking. It's more concrete. And look what happens to our sense of time. I really don't want to think about the rest of my life or the broad future. What I can tolerate is days and hours. And if you ask me to think about next year, then I might flip my lid and fall out of the window of tolerance. That's what happens, right? It pushes us too much. Or if you talk about that emotion now, I might fall right out that window of tolerance because I was already just teetering on the edge of that. Yeah, Stephanie.
Oh, I don't know if you could bring up that slide again.
Yeah.
So
there.
it was a thought in relative to how we kind of can understand, when we look at office discipline referrals.
Yes.
One of the motivations that's identified is like avoid task, avoid peers, avoid avoid something. Like, we have avoidant behavior and attention getting behavior and things like that. And I'm just looking at this alert state where this flock. And so a student who's demonstrating avoidant behavior, they're uncomfortable, but they're not necessarily in a state of alarm yet, and so there's but most teachers kind of see that and they see, okay, this is a problem and we need to stop this right now. Right. Whereas we could recognize it instead as they're engaged right now.
Yep.
Even though it seems like they're pulling back, like they're paying attention to what's going on. And if we can kind of, I'm thinking from a classroom-based perspective, kind of recognize and channel that and not, go to the exclusionary discipline practice,
right?
But to really pull them into that flock. And I don't know. I'm just
so important
because we see that so much, and we can analyze ODRs for behavior motivation, and that seems to be that channel where that exists.
Yes, right. We can think about that in an FBA kind of way. There are a few terms that are troubling to me from my perspective, and you work with schools, so you name them so well, right? So two are attention-seeking behavior and task avoidant behavior. And it's in the frame which directs our approach. So I'm really glad you brought that up. So number one, we can think of, the kid is still at least within their window of tolerance. What's going to save us now and keep them there? Because once they're out of it, it doesn't matter. You can do whatever you want. It's not going to matter until they're back in that and we can get some reasoning into them. So how are we going to keep them there? But if, as you're pointing out, if our savior there, and I'll pull the chart up again, is flock, which it is, right? If they're able to use people safely, if this is within a normal range, they can use people safely, our best bet is to engage in a flock response. And if my belief is you're manipulating, you're task avoiding, or you're attention seeking, my response is not likely to produce a flock response, right? Because I'm going to ignore it to try to extinguish it in some kind of way. The worst thing you can ever do to attention-seeking behavior is ignore it. That is the worst thing you can ever do. I'll just repeat that. If somebody's engaging in attention-seeking behavior, is to ignore that behavior. It will exacerbate it tenfold. So Stephanie, you're so good at like getting me on to these issues, and it's you guys. So I want to be really honest. I find that many aspects of a behavioral approach are highly inconsistent with a trauma-informed approach, very misunderstood and misguided, and often very unhelpful with traumatized kids, and in my humble opinion, most kids in some cases. So I want to recognize that and say that out loud to you guys, that I am not a big believer in behavioral principles, and there's a ton of research to indicate that we've been really misguided and that it's not particularly helpful. And what I love about MTSSB is that we have to figure out a way to set up a tiered system of responding to need. What I don't always like is that PBIS has been identified as the premise of that approach, and that's where I would depart. So I know that's not true for all of you. I'm just so you know how to take where I'm coming from. That is definitely true, and we could talk at length about my departure from behaviorism and why that's the case.
No, I think it's helpful to kind of keep these conversations going, because I think that they're not fundamentally incompatible, but there are some acknowledgements that we need to make, that when we look at things from a behavioral lens versus a trauma lens, it's, that we make different assumptions about what we see. And so, but the more we can educate each other and talk about that, the more we can make informed decisions and, appropriate responses. So
we have to talk about it, right, Stephanie, and figure out how we reconcile. And, in my opinion, that's about being a good educator or therapist. I do not believe the same things I believed 25 years ago. I wouldn't have said any of these things. I was the best behavior chart maker ever. So I think we also have to recognize that there's an increasing level of complexity in the world, and that we know a heck of a lot more than we did 25 years ago about how people grow and change and about the brain. And it's hard to shift, but it's our responsibility to shift with the new information that we have. And there are plenty of behaviorists, right, that I work fabulously with, and we have a very similar frame. And there are other frameworks, again, where I think they're just fundamentally inconsistent, and we have to figure out how to reconcile that. Yeah. Any other questions or comments while we're paused? I haven't heard from everybody. Are we doing okay? Becky, are we doing okay? Yeah, okay. Michelle? Okay. Dave? Oh, he smiled again. That's good. All righty. Well, let me jump in and see where we get to today. And again, I'll figure out how to wrap in any other pieces. I would much rather, you guys, we have this discussion and make the material rich and integrate it into your work than me just go through a PowerPoint. So thank you. I appreciate it. All right, so we were thinking, and I'll show you a chart later about kind of immediate implications of intervening, but already you can think about, if I'm working with a staff, I was just with a staff all day yesterday, a school staff, and I come in the room and I recognize that people are like upset, aroused, anxious, all those kind of things. What I don't do is come in talking about long-range goals and extended future, because it'll push them outside of the window of tolerance. I focus on days and hours. And if people are even more worked up, then I deal more with emotional content, and I shorten the time frame. What's going to happen in the next hour? What are we going to do next? And you can begin to get people back in that window of tolerance. So once I'm in an alarm state, right, we're down in the limbic system. You see resistance and crying, or kind of robotic compliance. There isn't as much up here. We're teetering, like Stephanie said. Once you get into alarm in the limbic system, you've got to have a relationship that you can co-regulate with if we're going to get you back into the window of tolerance, or do a good amount of regulatory activity with people respecting your intimacy barrier, which I'll talk about next time. And then fear is you're going to see tantrums, aggression. You'll see like this going back to uterofetal rocking people will do if they're really distressed at that point. And the ultimate animal, you see this in mammals too, response is, you know, outright limbic system aggression, fight for your life aggression, where you just see that kind of glassed over look. But then on the opposite end, think of an opossum fainting, right? So this is all reflexive. You don't have any sense of time once you've entered a state of terror. And just some of our very high-end kids get into this actual state of terror. Most of the time we're hovering around these kind of stages. So this is a lot to share with you guys. I just had to sneak it in there because we're thinking about individual impacts. We're thinking about interpersonal impacts, and then we can think about system impacts. And schools have been through a lot the last few years. And so I have found that staff need just as much regulatory support as kids do, to be really honest with you. So what's happened here is they've just aligned state-dependent functioning with how a group might function. And I thought you guys might think this is just kind of interesting to think about working and consulting with groups of people. So if you're in an environment, and I wouldn't put Northern Urban Services in it for those folks that are from there, right? That's been, you know, lots of resources, super predictable, stable and safe for long. I don't know if it's even schools lately that have been in this boat, if I'm honest with you guys. Then, kind of like with state-dependent functioning at the group level, collectively, people are able to have a good level of IQ. They can think abstractly. Emotionally, the group stays pretty calm. People are reflective and innovative and really thinking about being intentional about the future. They can engage in some more abstract thinking like we are around discipline, et cetera, today. And then when they're with staff, they're nurturing, they're flexible, they're enriching, just like we're talking about with students. Whereas if we've had now some resource limitation and some, you know, difficulties in terms of predictability, then you'll see, just like with an individual, right? People get much more concrete. In my world, that happens like, just tell me what to do. Just tell me exactly what to do every single time to make it better, which just isn't the reality, as you all know. So the prevailing tone becomes anxiety. And people get really simplistic and concrete. And I think that's why behaviorism gets tied into this, because it feels so tangible and so concrete for folks. And it's what we've been taught. And so our focuses get a little more short term, right? Yeah, we could probably motivate somebody. I don't know if we'll get that today, but we could probably motivate somebody at least temporarily with a consequence or a reward. But in long term, if we can tickle intrinsic motivation, we're way better off, right? So how do we support that? So then you can see this happen in both policies and practices that are just super cautious, paranoid. I see this a lot, and I'm just going to put this out here in school safety planning these days, like around, you know, the threat of mass violence, which is so exceedingly rare compared to the amount of violence students are experiencing in their everyday lives. It's a little bizarre to wrap your mind around. And then last but not least, and then I'll come back, is if you've been in an area where it's just been a lot of, you know, really lack of resources, inconsistent, just a threatening type of environment, then you see that similarly in behavior. People are more reactive and regressive. Fear. This is our society right now. Everything's based on fear, it feels like, and people are super reactionary to what's happened. It's hard to get out of what am I going to do now? And so people can become either apathetic or more oppressive and harsh with others when you've been in those systems for a long period of time. So hopefully that you can kind of see the parallel of those two things, that some of those things we see in the folks, we can also see in how our systems, our school or our mental health systems start to function as well. Yeah, Stephanie.
It's both super uncomfortable and super valuable to acknowledge that last slide, and the the state of education as it has evolved in the last few decades to becoming more reactionary, and feeling more toxic, and really understanding where those, like when we look at teacher burnout and things like that, like when we look at it at that systemic level, I haven't seen that before, and really understanding that we are, as an educational system functioning in a state of distress.
Yeah.
And I kind of like what I was thinking, Stephanie, and what you were saying. Cassie, is that I'm a teacher who just left education in April. I am one of the thousands that have left, and knowing what I just left and going back to what you were saying. And I was just sort of thinking about, like, you were saying, if you sat in a meeting with goal setting and you know that people aren't in a state to handle that, but our schools, that's what exactly they're doing. They're not in a state to really move to those goals because there's so many underlying issues right now. And I think this is where MTSSB systems are really important to help build those supports so we can get to that place. But it's hard to get there if nobody's in that position to do that.
And system building takes a lot of time. Right,
Yeah,
guys?
and they just want to jump over it.
And they just want to make it better. Just make it better now.
Right, exactly.
And then when I come along and I'm like, okay, the way to make it better is we have to talk about the hard stuff. People are like, what? What? I'm just going to teach them a social skill and it's all going to go away.
Exactly.
I wish. That would be great, right? You know, trauma informs about contextualizing. And it's the same backdrop Stephanie was talking about with a parent. I'm doing the same thing for an educator. I'm not going to come in and say, it's how you operate. I know how systems function. I know how community mental health functions. We could look at Bloom and Farragher signs of traumatic systems, and they are my, decade of experience in community mental health. It takes on the culture, right, of trauma, and those systems look very much like that. And I think of all my amazing work for 5 years with the DOE and school districts here. It was hard for districts to stay with it in the end, when there wasn't a simple, quick solution at the end of the day. If I'm honest with you all, I've thought long and hard about this, that I don't think any of the real change comes, and maybe you guys are much better than me, but it takes 5 years at least to really get a systemic change where people are believing it and it's, evidenced in their behavior and culture change. And schools, they often talk about a sign of secondary stress is constant initiative change. So part of it is like, there's just so much new stuff that comes in and people feel like they're constantly bombarded with something completely new. I do work hard when I talk about trauma-informed or brain-based education to say, this is nothing new. This is not, a new approach per se. And frankly, it doesn't cost any money or a brand new program. It costs nothing to benefit from all this. Just how we are. Anyway, we have 10 more minutes. I got to try to do a little bit more. You guys, you've been wonderful. Let's see here. Got to pull up my PowerPoint. All right. I do want to introduce, I'm at 79 of 120, like I shared at the beginning. I like to have everything there so that we're able to go there. Oops, I do want to share this with you guys because it's really got us to where we are, and then I'll think about kind of our last piece for today and pick up next time. So when we respond to thinking about state-dependent functioning, the way you do this is called the sequence of engagement. My whole life, I'm thinking about how do I and other people work the sequence of engagement, and some of it is about a rotation of the type of activity. We can talk about this more later, but same brain model. As you recognize, brainstem is getting bombarded at every moment, internally from stimuli, externally from what's happening to us. And the first thing we have to do is just feel like our immediate survival isn't at risk. That's the brainstem down at the very bottom. If we can get that way, right, that we're not in immediate risk, the next piece is the diencephalon and cerebellum, as you know. That's regulation. Remember what we talked about, like movement, rhythm, body, sensory motor in space. Those kinds of things, if we can feel safe, if we can be somewhat regulated through those kinds of things, we'll talk about that next time too. The next piece is now I might be able to connect with another person. He refers to that as relate, right? If I can feel safe enough, we go back to that flock response we saw on state-dependent functioning. And then if I can get all of those satisfied, great. Now my brain ignites. And we don't need huge parts of insight, if you will, in order for this to happen. But what we have to do is always come back down to the bottom of the sequence engagement and build up. And we can do a lot of this, again, through tier 1 type of activities. So you can build, and when I worked with the teachers through the DOE, we spent 4 full days together making toolkits. There's a million resources out there, but like an entire day on everything you could do for safety, an entire day for all these regulatory activities you could do. So you could think about these in buckets, and then all these relational activities, and last but not least, meaning making activities. So I have a ton on each of these things as we begin to think of them. And when we think about brain-based interventions, I had to get a lot on here for you all, but let me just kind of talk us through this. These are those same 4 regions. And I'm always thinking about, for all of us, teachers too, to what degree are we satisfying these? And the more compromised my brain is, obviously the bigger ratio of bottom-up interventions that we're going to want to have. And so safety, there's really, I'll just do this slide and then we'll think of a wrap up. Safety, there's really 4 kinds of safety. We're often focused on physical safety, keeping hands and body to ourselves, but it's also, can I keep myself safe with other people? Psychological safety is somebody's ability to have their own identity, right? This is who I am. This is what I like. And we get that through mirroring in relationships, being seen by other people helping to understand this. We don't get it when people are trying to make us or behave differently. We don't get the same sense of identity. Social safety, this is Bloom and Ferreter's work, but social safety is, where do I belong? They refer to it as social immunity. So often I think about breaking up lots of different small groups of staff or kids so that we can have more opportunities for social immunity and not pre-established groups. When do I feel worthy and when do I belong? And then last but not least is moral safety. And I think if we look at the systemic impacts and where educators are, moral safety has been utterly robbed. And moral safety is when you feel like the system you work or you operate in is run by the values that you hold dear. And we could start getting out legislation and looking at where teachers are at, but that is not the case right now when I meet with teachers. They don't get to make many important decisions about work that they value dearly. And when we start talking about trauma, and especially the extended ACEs pyramid, it certainly is going to encompass things like systemic oppression and racism. And there have been real limitations in how teachers are talking with students about these things. So that gives you an example. So those are the kinds of activities when we think about safety and what those would look like. When we think about regulation, we get overly focused on what they refer to as top-down regulation. That's self-talk. That's remembering what zone I'm in and adjusting my behavior. And the problem, as we've been talking about with state-dependent functioning, is if I'm really dysregulated, I don't have access to that part, right? So you hear teachers say to me all the time, they're so good at zones and then they don't use it. No, they can't use it when they're outside the window of tolerance, right? They don't have access to it in the same kind of way. They might know it's there, but I'm sure you all have had a meltdown before that you're wishing you didn't have, and you know you shouldn't do it, but you do it anyway, often with primary family of origin. So then there's bottom up, sensory motor stuff or movement type stuff that we do on a regular enough basis. And then relationship building activities, anything to improve the student-teacher relationship, peer-to-peer relationship, and at the bottom of that, social skills, but genuine, authentic relationship building rather than social skills will go much, much further, in my opinion. And then meaning making. So looking at what experiences we had, I talked about the trauma responsive framework briefly earlier, what experiences we've had, what the impact of those experiences have been, positive or negative, could be post-traumatic growth, and then how we're going to move forward in the future. And what I've tried to share with us on these bottom two is that for relationship building, because of attachment, the increment starts small. One-to-one-on-one is about all that can be tolerated for many folks. And what we're trying to do is move up to the large group that somebody can be okay with. And when we start thinking about experiences, we're thinking about all kinds of experiences. If present experiences, what's happening that day, can make meaning of how somebody's behaving, fine, I'm great with that. But that often doesn't do it. It has to do with other things, other kinds of experiences and relationships. And so putting those together can help kids and adults transcend those very circumstances. About 4 minutes left. I'll just flash this and we can come back to it. So you could already see, if you wanted to provide guidance to folks thinking about the sequence of engagement, right? And state dependent functioning. And you could think about each of these as restful, vigilant, freeze, flight, or fight responses. And we could think about, well, if a teacher did this, it would pretty much predictably calm or de-escalate, or if they did these, it would probably be escalating. And here's the primary part of the brain we're working with at that point in time. And here's what thinking is like. People's kind of like this. It feels more concrete. It's all things intuitively you guys know, or that we know about interpersonal functioning, but particularly aligns that with where somebody might be in a particular arousal state. And I'm not going to read all those for the sake of today. I just wanted to kind of pull that up for you before we closed.
This is such a useful slide for teachers.
I will share to you guys so you can see where we're at right now. Where we would have been into regulation. So I'll figure out a way to kind of bring us around. I feel like the core concepts and objectives that I wanted, what we didn't talk about is optimal conditions for learning. And those are really going to follow in many ways on those 4 buckets that I was talking about. Optimal level arousal, safe and supportive relationships, predictability and routine. But I can come back to those in the relational context as well as we talk, okay? And I'm sorry I did so much like talking at you today. We just had so much material and so little time. I wanted to do justice to the work you all do. I'm really grateful for what you all do. I hope that what I'm sharing with you gives you some like deep rooted background to help you share with others why we really know in a brain-based way that this stuff absolutely works.
Well, thank you so much for being with us today. I know I really enjoyed listening to the last couple of